to introduce our webinar speaker for today and the moderator. But before that, on behalf of Dr. Katula, I would just extend an invitation to attend the AAPI annual convention, which is in Cincinnati, July 24th through 27th. And I know the teams are working tirelessly to bring a very energetic program out here, which is not just CME, but entertainment and everything, a full package that they're working on. And he'll be sharing lots of those as time comes by, but just save the date, July 24th through 27th, annual convention in Cincinnati. And we have few more webinars left for the year. So again, my apologies that it has sort of not been very consistent at a regular interval, but definitely, sometimes life happens for everyone, including the speakers and us. And so I just want to thank everyone, but definitely we are working on few more to bring it your way before the end of this year out there. So moving on to the webinar today, we have Dr. Utpal Pajwani, MD, PhD, Associate Professor of Medicine in the Division of Endocrinology at Columbia University. He's a physician scientist with clinical research focus in obesity-induced metabolic diseases. He graduated from MIT with a degree in biology, earned MD and PhD degrees from Albert Einstein College of Medicine, completed internal medicine residency and fellowship training in endocrinology at Columbia University Medical Center. He's been on the faculty at Columbia University since 2011, teaching, attending on inpatient and outpatient services. And he sees patients all across the New York City area, scholarly projects program for students at Columbia University, and his research focuses on role of developmental pathways in the regulation of type 2 diabetes and metabolic dysfunction, associated steatohepatitis, which is MASH, very similar to NASH that we always talked about. So there's something out there, and use of existing therapeutic agents and other scientific areas to ameliorate obesity complications, including cancer. And to moderate the session, have another great individual who is out here with us, Dr. Anuj Bhargava, who is from my alma mater, Maulana Azad Medical College in India. And he's a CEO and medical director of the Iowa Diabetes, the largest diabetes research center in central Iowa. He's also the founder of My Diabetes Home, a personalized tool designed to simplify diabetes self-management for patients and revolutionize office visits and clinical care. He's an adjunct professor of medicine at University of Iowa College of Medicine, and adjunct professor at Des Moines University, and associate professor at Drake College of Pharmacy in Des Moines, Iowa. And so with all that level of expertise, I just can't wait how the next hour is going to change what we know about diabetes. So I'll let Dr. Pajwani start his talk, and we'll be recording this talk as well to put it on the AAPI website. And thank you and welcome.
Yeah, I'll say a couple of things
Yes,
before
please,
you
go ahead.
start. Dr. Govil, thank you for the opportunity, and it's great to be here. Very much looking forward to a type 2 diabetes presentation, and just was very happy when I got information on Dr. Pajwani and how many different roles he plays, from research to teaching to clinical. Just looking forward to it. And he tells me he has 2 kids, married, and born and raised on the Jersey City side. So just looking forward to this conversation on a very passionate topic that has changed a lot over the last 2 decades. So looking forward to this approach. Utpal, go ahead.
Thank you. Thank you for the invitation. Thank you for the introduction. Very, very kind. My screen, you can see?
Yep.
Good. Excellent. Okay. Yeah, there was a time when we would do a lot of Zoom talks. Now I barely do any Zoom talks. It's just a lot of practice. But anyway, so my hope today is to make this as accessible as possible to a broad range of clinicians, right? And I really try to give this talk to make it very practically oriented, so that as the invitation for me was stated, like you get presented with a patient with new onset type 2 diabetes. Now what? How should you think about pharmacology? How should you think about management? And so, as alluded, my lab does a lot of research. We do research in liver and pancreatic beta cells, but this should be, I think, hopefully very relevant to your practices. And the reason I say I hope it is because diabetes, as you know, is very, very prevalent. These are the maps that everyone shows. Everyone showed these maps forever. And you can see that how prevalent diabetes has become in the United States and actually worldwide. There are, I think, more people with diabetes in India now, even than in the United States. A lot of it is a function of how many people there are in India. But if you look at the geography of the United States, 20 years ago, when I was starting residency, very few states had diabetes prevalence of 5%. Now every state has diabetes prevalence of at least 5%. Many have prevalence of 10% or more. And where I see patients this is Washington Heights. I don't know if you could see my little pointer. The diabetes prevalence rates are almost 15%. Which is shocking, right? So 1 out of 7 people have diabetes. And when I say diabetes, this is type 2. The type 1 diabetes in the United States, at least, is relatively rare. Maybe 4% of all people with diabetes. So this is predominantly reflecting people with type 2 diabetes. And so the reason I hope this is accessible and interesting for people online is there are so few endocrinologists. 2004, perhaps endocrinologists could see everyone with every person with diabetes who needed more than metformin, but now certainly not, right? So in our catchment area in New York City, my estimate is about 1.2 million people have diabetes. There are, and I don't want to mislead you, there are 4 doctors at Columbia who take care of people with diabetes. So we really need people, primary care, everyone who's primarily responsible for people to help take care. Okay. So again, I mean to make this very practical. And I started with metformin for a reason, right? So metformin is a medication, and this talk, by the way, is almost all pharmacology. There's going to be no mechanisms. There's not going to be any dietary advice. We could talk about that a little bit in question and answer, but really I mean for this to be all pharmacology. What medication to pick and when. So first-line therapy for people with diabetes is traditionally metformin, and it still is. There's some momentum to change that to some of the more recently approved agents like GLP-1s and SGLT2 inhibitors, like we'll talk about in a little bit. But metformin really does offer the best combination of safety, efficacy, and this is very important, cost. Metformin has been around, it's been approved in Europe 70 years. It's been approved in the United States for about 55 years. We know, I think, everything about metformin. Now, every year there's a new paper in Science or Nature claiming to discover another molecular mechanism by which how metformin works, but that doesn't really matter. I think we know clinically almost everything we need to know about metformin. We know that it's very safe. There are very few true contraindications. Many of the old contraindications have faded into the past, right? So this idea of heart failure, we know it's safe for heart failure. If the patient's admitted all the time for heart failure, maybe consider something else. The old cutoff of creatinine of 1.5 milligrams per deciliter for a man or 1.4 milligrams per deciliter for a man has thankfully been removed, and it's now all GFR cutoffs. If a patient is started on metformin and their GFR falls below 45, you can continue it until it gets to 30. So really, metformin is approved for use all the way up to basically CKD4/5, So keep it on as long as you can. But the problem with metformin, as many of you know, is that it has GI side effects, right? A lot of people will complain about mostly lower GI symptoms, diarrhea, constipation, loose stools, some upper GI symptoms like nausea and upset stomach. I have a specific approach for how I think about metformin, how I think about diabetes and pharmacology in general. People will have diabetes for the rest of their life, right? It's not an antibiotic you're prescribing. You don't have to get them to maximum dose quickly. You just have to keep metformin on board for as long as possible. And in large part because it is safe, it is efficacious. So I started a homeopathic dose. I wrote 500 milligrams a day, usually with a meal, for a minimum of 3 days. It doesn't do anything. 500 milligrams is really homeopathic. It has probably very little, if any, clinical efficacy. But I think it does tolerate people to some of the GI side effects of metformin. If a person is already predisposed to GI side effects, maybe they heard from their family or a friend that metformin is bad because it causes these side effects, keep them at this dose for a week, 2 weeks, doesn't matter, right? What's 1 week of uncontrolled blood sugars relative to where they were when you found them, right? You'd want to keep metformin on for the next 2 decades. At that point, I tell them to increase it to twice a day, 500 milligrams twice a day. Again, with food, it's helpful. And then I stay there until I see them again. You know, in my practice, I might see a patient every 3 to 6 months, depending on how they're doing. 1 gram of metformin, A1C average reduction of about 1%. You add that second gram in, you really only get another 0.2, 0.3%. That's pretty much a theme for all type 2 diabetes pharmacology. You get most of your bang for your buck at the starting dose. And then, so if you're escalating the dose too fast, or if you escalate the dose when the patient has side effects, you're not really getting much more efficacy, you're just getting more side effects. Yeah, eventually I get most of my patients up to the 2 grams of metformin, but there is no rush, right? They're going to have diabetes for a long time. It doesn't have to be A1C at goal in 3 months. Okay. Now that works for 95% of my patients. Really, I think it should work for yours. You tell people that, listen, we are aware that metformin has side effects. With your approach, the likelihood of this is near zero. And the psychology of this does work if you can convince the patient that you know what you're talking about. Okay, but then there are the 5% of people that even with your very low go, like the barbecue approach, you know, slow and low flame. But if your patient still has side effects, then convert to branded metformin, or sorry, extended release metformin, not branded. So this is the metformin XR, ER, used to go by brand names Glucophage, Glumetza. You might still know them as Glucophage and Glumetza. They're all generic, of course. Pick the cheapest extended release one for your patient, and then give them a try. So that with this approach, and I tell you this truthfully, 98% of my patients who I prescribe metformin stay on metformin, which is, I think, a little bit higher than the average. And I think a lot of it is like just a recognition of side effect profile and tolerability. Okay, now here's the meat of the presentation. After metformin fails, you know, I put fails in quotation marks because metformin doesn't really fail. People just progress in their diabetes career. They get more insulin resistant because of the combination of aging, which is irreversible, of course, and increasing weight, which can be reversible, but tends not to be unless you use one of the newer agents. So after metformin, what's best second-line agent? And this is from ADA, American Diabetes Association. They have a kind of a flow chart to try to help people decide what's best second-line agent. I don't love it. So I come up with my own algorithm of how I like to think of it. But the options are several, right? You can think of the options in terms of how they might work. Insulin sensitizers, we know insulin lowers blood sugar, right? So a molecule that will make the body more sensitive to insulin. And really, there's only one class of those. I mean, metformin, you can argue, is a sensitizer, but the major class is a thiazolidinedione. I know you're not prescribing a lot of it, nor do I, but we'll talk about it and why. Then the insulin secretagogues. So these are either glucose dependent, which are sulfonylureas, or glucose independent insulin secretagogues. And these are the incretins, either DPP-4 inhibitors or GLP-1 agonists or GIP dual agonists. There's insulin itself, right? Because if you're insulin resistant, you can overcome that barrier by giving more insulin. And so this is typically given as either basal or bolus insulin, long-acting or rapid-acting. And then the final category is completely insulin independent, meaning glucose wasting, and that's the SGLT2 inhibitors. So this is history. This is diabetes history. So this is when I was in training. This was a trial that came out called ADOPT, where they were looking at different options as monotherapy. This was before there was consensus about metformin being first-line therapy. A lot of people were using sulfonylureas, in this case marked as glyburide, or thiazolidinediones, rosiglitazone, which went by the brand name of Avandia. And at the time, people were like, well, which one is best first-line therapy? This trial was a durability trial, and it showed us that glyburide was not very durable compared to metformin, but actually the best on this list was rosiglitazone. It is the most durable. It's a very effective drug. There are two thiazolidinediones that have been approved in the United States, rosiglitazone Avandia and pioglitazone Actos. Now, the reason why you're not prescribing this, I suspect very much like is that even though it's an oral, even though it's very inexpensive now and there's no hypoglycemia risk, you're going to see my gray bars at the side of these slides to illustrate my pros and cons for each of the drug class. There is some significant cons. The true con, I would say, is that there's weight gain in almost everyone who takes this. So thiazolidinediones are PPAR gamma agonists, which means that a cell that has the option to become either an adipocyte or an osteocyte will become an adipocyte. And actually, that was my PhD research many years ago. So those adipocytes will then lead to weight gain, right? So everyone on TZDs will gain weight. But because they also get fewer osteocytes, they'll have a decreased bone mass and an increased risk of fracture. There's also an edema risk because of, and that might even progress to heart failure. So there's lots and lots of reasons not to prescribe this. The cardiovascular risk is interesting, actually. So this was noted in kind of a meta-analysis done by Steve Nissen a number of years ago. I remember going to American Diabetes Association when he was presenting this data, and it was like a shocking piece of data because he had shown, compared to pioglitazone Actos, rosiglitazone Avandia seemed to confer a greater risk of cardiovascular events than placebo. And so this was meta-analysis. This was never seen in RCT either before or after this came out. But it got a lot of news, right? And so this is the New York Times article on this. And after this came out, I'll get to that in a second. So this is my other sort of way I classify medication. Do I use these medications or not? Yeah, I don't use a lot of these. There is interesting data for pioglitazone in post-stroke. There's interesting data for pioglitazone in patients with MASH and type 2 diabetes. So the very few patients I have on pioglitazone are people with diabetes and fatty liver and established fibrosis. I don't have anyone on rosiglitazone. But the major reason I bring this up front even is because it led to this. The fallout from the rosiglitazone studies was guidance from the FDA. In the past, in order to be approved for use in diabetes, you had to show a reduction in hemoglobin A1C. Hemoglobin A1C, as you all know, is a 3-month average as to blood sugar. After the rosiglitazone data came out, the FDA has basically said, that's not enough. You have to show at minimum that your drug doesn't increase cardiovascular risk. Preferably, it should show cardiovascular benefit because you're treating diabetes for several reasons. One of the reasons is to reduce cardiovascular risk. But the absolute minimum should be no increase in cardiovascular risk, which was purportedly shown for Avandia. Now, that has stifled innovation in diabetes pharmacology for a long time. But it's also been such a gift because what that has then resulted is in our knowledge of how some of the more newer medications that we now prescribe for diabetes are actually beneficial. And not only are they beneficial for people with diabetes, they're probably beneficial for people without diabetes too, in both cardiovascular and renal outcomes. Okay, so that was the only sensitizer that is available, pioglitazone, right? There's a number of medications that push more insulin out of the pancreatic beta cell. So the pancreatic beta cell really has one job, is to sense glucose and put out insulin commensurate to that glucose. It's been known that there have been drugs that can increase the insulin secretion from the pancreatic beta cell for a long, long time. So the sulfonylurea class has been around for a long time, over half a century. They are classified as short-acting or intermediate-acting or long-acting, depending on how long the drug actually hits the sulfonylurea receptor on the pancreatic beta cell. More recent than that are the meglitide class of medications. So the meglitinides are, you can think of it as ultra rapid acting sulfonylureas. So for instance, if a sulfonylurea, you might think of it as regular insulin. The meglitinides you might think of as insulin analogs like Lispro or Aspart. They both have some cautions with use in kidney disease, in large part because they are cleared by the kidney. So then they're going to stick around a lot longer in people with CKD. And actually, I remember my first patient as an intern, little old lady, 75, on glyburide, came in, acute kidney injury, and I was pushing D50 all night because it wasn't clearing from her system, right? And so she was kept going down to glucose levels at 20 and 30 and thankfully not seizing. Okay, so there are many pros to this class of medication. They're oral, they're very inexpensive, right? So these are your cheapest options for diabetes therapy: metformin, pioglitazone, and sulfonylurea. They're reasonably efficacious. If you take a patient who has an A1C of approximately 8%, you can bring their A1C down for about 1%. And like I mentioned, they've been approved for a long time. We have extensive experience. There's also quite a few cons to this class of medication, right? Yeah, so there's weight gain, right? So anything that increases insulin levels typically is associated with weight gain. That's insulin itself or sulfonylureas. It's thought that the weight gain is due to hypoglycemia, either clinical or subclinical, right? So if you're giving a medication that will increase insulin secretion, independent of what the blood sugar is, which is like the sulfonylureas, right? If your blood sugar is 100, or if your blood sugar is 300 and you take and sulfonylurea, it's going to bring your blood sugar down the same. Like the beta cell doesn't care because you took the sulfonylurea, the blood sugar will go down. There's no cardiovascular benefit. In fact, the sulfonylurea class is likely safe. It is the comparator class for many of the drugs that follow in these cardiovascular risk algorithms. So these are the sulfonylureas. These are the meglitinides. I do use them mostly because they're cheap. And I think there are a number of people for whom cost is a big consideration. These are available for $4 a month at Target, Walmart, $10 for a 3-month supply. Very inexpensive. They have a lot of downsides, including weight gain, hypoglycemia, and their effects are not durable. Remember the ADOPT trial I presented earlier from 2005. They're not my usual second-line therapy, but they are useful in specific cases, right? Someone who's glucose toxic, A1C 9%, 10%, you might be able to get some headway with sulfonylurea because it really pushes out a lot of insulin. It's not my favorite use of it, but it's historically been used in that patient. The major benefit is it's inexpensive, right? So if you have a patient who's uninsured or underinsured, this might be a medication that you choose. Within the class, my preference is for the shorter acting drugs like meglitinides or glipizide as compared to longer acting medications like glyburide. In truth, probably you shouldn't be using any glyburide in your practice because it's just too long acting. The risk of hypoglycemia is too high. Okay, now the glucose independent insulin agent, the sulfonylurea, has largely been supplanted by glucose dependent insulin secretagogues. And these are the incretins, right? So what is the incretin effect? The incretin effect has been long recognized, several decades, that if you were to give a glucose load, like a glucose tolerance test, oral versus intravenous, the oral stimulus gives more insulin secreted than the intravenous stimulus. Now, we don't do a lot of intravenous glucose tolerance tests in people. Many people have gotten oral glucose tolerance tests, right? Pregnant women for gestational diabetes screening. But in research perspective, that difference between the amount of insulin secreted with an oral glucose load versus the exact same IV glucose load, that's the incretin effect, okay? And the incretin effect is mediated by, generally speaking, 2 hormones, GLP-1 or glucagon-like peptide 1 and GIP or glucose-dependent insulinotropic peptide. And these are both made normally by the enteroendocrine cells in the gut, either K or L cells. K cells make GIP, L cells make GLP-1. And that's where the endogenous incretins come from. GLP-1 is degraded by an enzyme called dipeptidyl peptidase 4 or DPP4. Okay. So the first drugs that were available of this class is the DPP4 inhibitors. so the DPP-4 inhibitors, they're still billion-dollar drugs, but they're decreasing in popularity for a couple of reasons. First one on the market was sitagliptin or Januvia that was made by Merck a number of years ago. There are some renal dose adjustments for pretty much all the drugs in this class: sitagliptin, saxagliptin, alogliptin, and linagliptin. The reason why these were promoted initially by companies is that they are orally available, and that was a very big thing for a lot of companies to make sure that their medication was orals. And there's no dose titration. So if you wanted to start someone on Januvia, for instance, it's 100 milligrams. You don't have to titrate up or down. It's just 100 milligrams. I mean, if they have CKD, you might have to use a lower dose, but 100 milligrams, you don't have to escalate or de-escalate. They're completely weight neutral, in large part because they're not really making any impact on the beta cell unless the blood sugars are high. Remember, these are affecting incretin responses, which are glucose dependent. Meaning if the glucose is 100 and you take an incretin, even a DPP-4 inhibitor, you're not getting any more insulin. But if your glucose is 200, you are going to get more insulin in that context. They're weight neutral. There are no hypoglycemia. The cons, there's no cardiovascular benefit. This is across the drug class, right? So these drugs were all developed long after the rosiglitazone FDA issues. And so these drugs had to be extensively tested for cardiovascular safety. And they're very safe. They really have no side effects. They have no cardiovascular risk, but they also have no cardiovascular benefit. They're all branded still. There's no generics yet available, so they're all fairly expensive. And they have really modest efficacy. And this is across the drug class. So this is a meta-analysis that was done about a decade ago using the 4 available in the United States and one additional vildagliptin that's available in the EU. Across the drug class, you're really only expecting about a 0.6% A1C reduction, which is pretty minor, relatively speaking. So if you're going to ask someone to take a medication that might cost a few $100s a month and you're getting 0.6% A1C reduction, you really have to think about, is that worth it for you? And for a long time, it might have been. But now that we have much more potent agents, specifically GLP-1 agonists, it may not be worth that same cost. And why they're not that efficacious, because we've all heard of Ozempic and how efficacious it is. So why is this not the same, right? It's in large part because it's only increasing endogenous GLP-1 levels, maybe 2 to 3-fold. Whereas when you're taking exogenous GLP-1 with the injection, right, you're really getting a very high level of GLP-1 in your circulation. And so it's much, much higher GLP-1 than you can achieve with DPP-4 inhibitor. Okay, GLP-1s, right? So this is very popular now throughout the lay press last few years, leading to shortages of the more popular GLP-1s. In the past, maybe you had to convince a patient to take an injection. Now patients come to you asking for this, right? Even patients without diabetes are asking for Ozempic. So the first one on the market was exenatide, which went by the brand name Byetta. It still does. It was subcutaneous. All these are subcutaneous injections except for the one that I've labeled PO, which is Rybelsus. So exenatide is twice a day. So this was the first one. So this is the one that was derived from Gila monster spit, right? So this was developed at the Bronx VA by a scientist named John Eng a number of years ago. And people were like, why would I take this, right? In large part because you're taking an injection now twice a day. A1C effects there were about 0.9 or 1%. It's better than a DPP-4 inhibitor, but an injection twice a day that made you feel a little sick to get a little bit of A1C decrease compared to DPP-4 wasn't very popular. The first one that was popular was liraglutide, which went by the brand name, still does, Victoza, because it's daily. The difference between twice a day injection and once a day injection is huge, right? And it was very easy to convince people to give Victoza a try, but not anywhere as easy as it was once the weekly injections came about. The first weekly was Bydureon, which is exenatide extended release. It's weekly, not used very much anymore for a couple of reasons that we'll talk about in a minute. That was largely supplanted by dulaglutide, which went by the brand Trulicity, and eventually Ozempic. I put down the starting dose and the max doses here. And here, this is a very critical point. How to titrate these doses. In the package insert, they're going to tell you something. Please don't do that. how I do it is you start at the lowest possible dose. For some medications like Ozempic, there's in fact a priming dose. Like the first month of Ozempic is not even at the starting dose of 0.5. It's like at the practice dose of 0.25. Think of it as like the homeopathic 500 milligrams of metformin. So let's say you want to prescribe Ozempic, 0.25 milligrams weekly for 1 month, and then titrate up to 0.5 milligrams a week, and then leave it there. Do not go up. Yes, there's incremental benefit from going from 0.5 to 1, and there's incremental benefit even going up to 1.7 and 2.4, the weight loss agent doses of semaglutide, but leave it alone. In large part because at 1 month, people might still have some nausea. Now, the thing about nausea is in trials, the nausea rates are 30 to 40%. In my practice, the nausea rates are about 10%. In large part because in trials, they're really escalating the drug very fast, right? At 1 month, they're going up from 0.5 to 1 milligram of Ozempic. People are just coming off their nausea at 2 to 4 weeks. Leave them alone for a little while. Again, it's not a race. It's not a 100-yard sprint. It's a marathon for these people. You want them on the medication for as long as possible. The other thing about the nausea and the discontinuation rate. So in the lay press, people often quote this number of 50% discontinuation rate of GLP-1s at 1 year. In my practice, it's about 3%. Now, some of this is bias in patient selection. People might be coming to me in large part to obtain GLP-1. They're kind of a vested interest. Another part of it is access, right? So a lot of the discontinuation rates in GLP-1 is because either supply issues, which were more of an issue 2 years ago, or payer issues. What's once approved is no longer approved, and you have to do a prior authorization, then you have to do an appeal, and it's a giant pain in the butt. Of course, that's all true, right? And then I'm in an academic practice, and there's an MA who might help me with my prior authorizations that maybe if you might not have. The other part of it, though, is I prep my patients. I say, you will be nauseated. I tell them, listen, most people will be nauseated with this medication. It's not true. In trials, it's less than most, right? It's about 30 to 40%. But I tell them most people will be nauseated, but stay with it. It'll get better in 2 to 4 weeks. So by the time they're doing their 3rd or 4th injection in that box of 4 pens, they're already feeling better. Now, there's a number of people who will never be significantly nauseated, and they feel very lucky. The remainder who do feel some nausea are like, okay, Dr. Pajwani said it was okay to stay with it. And then by the time I see them next in 3 months, they don't even remember it. Now, in 3 months, you might be tempted, okay, maybe I should escalate the dose from 0.5 of Ozempic to 1 milligram of Ozempic. If their A1C point of care is now 6.5, leave them alone. You might need to get to 1 milligram at some point, but there's, again, no rush. There's no study that actually shows a benefit of 1 milligram of Ozempic for an outcome than 0.5 milligrams of Ozempic, for instance. There is an incremental A1C benefit going from 0.5 to 1, but really it's 0.2, 0.3%. And so you really have to think carefully about when to titrate up. Yes, they might get to 1 milligram eventually, but it doesn't have to be now. Okay. And so this is the same point more graphically. This is data from Trulicity, right? So the first dose of the first approved max dose of Trulicity dulaglutide was 1.5 milligrams once a week. Eventually, they came out with the 3 milligram and the 4.5 milligram options, and you can see here all 3 of those look very good, right? So they all had about 1.4, 1.5% A1C lowering. There's not a lot of difference between 1.5 here and 4.5 here. Yes, it's lower by about 0.2%. And actually, if you look at the weight loss curve, it's another 4 pounds. And that's great. 4 pounds additional weight loss, 0.2% A1C, those are all benefits, right? And when you have someone who's plateaued in their weight, and if you have someone who hasn't gotten to A1C goal, yeah, then escalate, but there's just no rush. And I could have done the same data with Ozempic. It looks just the same, you know? So no need to escalate therapy quickly or to maximum dosing. Some people may never get to max. Now, how to choose which one? Like I just gave you this list. Some of it's based on patient preference. Like, you know, people come in asking for Ozempic, right, by name. They may not even know what it is, but they ask for Ozempic by name. If they're asking for something, they've already kind of have a vested interest in it. If it's provable, that means they've already kind of mentally bought into it. You do have to play into that a little bit. You also have to base it on efficacy expectation, right? So if their A1C is 8.5 and they need a medication to get them 1.6, 1.7%. You know, Trulicity might not get there. Rybelsus, the PO semaglutide, won't get there. You really need Ozempic or higher, right? So then you have to base a little bit on what kind of expectation of A1C reduction you want to get. Cardiovascular and renal data, there are some exciting cardiovascular outcome studies and renal outcome studies. And then insurance coverage, right? So these are expensive medications, right? You know, even with recent drops in prices, it's still going to be out of pocket $400 or $500 a month for most people without any insurance, or if their insurance says no to a specific agent. So there are some insurances that prefer step therapy, do the step therapy, get them to the drug you want eventually. There's some insurances that will prefer, for instance, Trulicity instead of Ozempic. Fine, do Trulicity, and then if they can't get to goal, then consider escalation to Ozempic. But it's a very important concept now for these medications, in large part because these medications are quite expensive. Okay, so the cardiovascular outcome study. So this is the data for semaglutide sub-Q Ozempic, right? And so this is the primary outcome of 3-point MACE, or major adverse cardiovascular events, which is non-fatal MI, non-fatal stroke, or cardiovascular death. And so these data were published in the New England Journal about 8 years ago and showed clear superiority for Ozempic compared to placebo. Now, remember why these trials were done. They were done in order to establish safety, lack of harm, but actually these medications are showing benefit, right? And it's not just Ozempic. It's almost across the drug class, I would say. There are some GLP-1s that don't show a benefit. The ones that don't show benefit are ones that you're probably not using. Lixisenatide, which has really never been approved for solo use. It was in a combination of insulin GLP-1 product called Soliqua that I did use a bit of. But pretty much all the GLP-1s across the drug class have shown a cardiovascular risk reduction, which is amazing, right? So, and if you were to do the meta-analysis, about 15% relative risk reduction. Some are a little higher, like semaglutide. Some are primarily in a primary prevention group, like dulaglutide and Rewind trial. And some show no benefit at all. So these are really exciting data once published. Actually, the first cardiovascular outcome trial in this class was liraglutide, which was the leader trial, which was published about 10 years ago, which showed that. And so I don't think all of this is just A1C reduction, by the way. I think there's some non-A1C benefits being conferred by GLP-1s. Now, these are even more recent data. The renal outcome, this was quite unexpected for me, at least. Many of the same medications that show cardiovascular outcome are also showing improved renal outcomes. Now, these are the ones that I'm showing in the meta-analysis are relatively soft renal outcomes, doubling of serum creatinine included. But actually, some that are more dedicated towards GFR trajectory or renal death have also shown benefit, including semaglutide in FLOW. And so the mechanisms of this are still being considered. There's a lot of putative mechanisms for GLP-1s. Some of it might be weight loss. Some of it might be direct impact of the GLP-1 on the kidney or in the vasculature of the kidney. I'm certainly not an expert in this, and I'd be curious to see how these data play out in the long term. Okay, so up, down, do I use these meds? Of course I use these meds, right? We all use these meds. You know, they are in fact my preferred second-line agent. You know, even 4 years ago, it was hard to convince people to take an injection. That has completely changed in the last few years. They have high efficacy, these medications. They have an impact on body weight that's favorable. And they have almost no risk of hypoglycemia. Yes, there's some risk of hypoglycemia if you're combining it with a hypoglycemia-inducing agent like insulin, but really on its own, there's very little risk of hypoglycemia. In this drug class, I prefer dulaglutide Trulicity due to primary prevention and Rewind. Many of our patients have never had a cardiovascular event. So all these cardiovascular outcome studies that we talk about, these are all in people who've already had an event or who are extremely high risk. So they may not apply to a healthy 50-year-old who happens to have type 2 diabetes and has never had a cardiovascular event. That patient might benefit from Trulicity, you know? The use case for Trulicity is also interesting. You know, I take care of a lot of East Asians and South Asians who get diabetes at much lower BMI than a Caucasian or African American reference population. And so 10% weight loss, which you might achieve with Ozempic in a person with diabetes, might be too much weight loss. So actually, you might want the A1C benefit of Trulicity with much lower weight loss. I don't use a lot of Rybelsus, in large part because Rybelsus efficacy is closer to DPP-4 inhibitor than it is to Ozempic. It's also not taken very frequently correctly. So Rybelsus is the oral version of semaglutide, and it goes to doses of up to 14 milligrams a day. First of all, it's 14 milligrams a day instead of 1 milligram a week. The other problem is you have to take it with 4 ounces of water, nothing else to eat or drink for half an hour. And very few people will do this. Very few people will incorporate that sort of medication properly in their lifestyle. So actually, real-world data with Rybelsus, probably the A1C reduction is even less than in trials, where the A1C in trial reduction is about 1%, as compared to like 1.6, 1.7% from Ozempic. You don't get as much weight loss, you don't get as much A1C benefit. So I try to make the point to patients, and I think they buy into it, that I'd rather do 1 injection of Ozempic instead of 7 oral tablets of Rybelsus. And most of my patients do buy into that. I use DPP-4 inhibitors very uncommonly as second line, only in patients whose A1C is really in the low 7s, because really you shouldn't be expecting more than 0.5, 0.68% A1C lowering. If your A1C target is under 7, and you have a patient who is an A1C of 8.5 and you prescribe Januvia, they're not going to get to under 7. They'll get to 7.9 approximately, right? So they're interchangeable too. Okay, Mounjaro. So this is not technically just a GLP-1 agonist. This is a GLP-GIP dual agonist, right? And this is the quote-unquote newest incretin. It's been on the market now for several years. These are data from SURPASS-1, which is the pivotal data that led to its approval and use in type 2 diabetes. Look at that efficacy, right? So at starting A1C of 8%, the people at the highest dose of Mounjaro of 15 milligrams got to in the pre-diabetic range, so under 6%. So people are getting 2.1, 2.2% A1C reductions, which is astronomically good, right? And a lot of this is based on both the effects on the pancreatic beta cell, but also due to the fact that this is really an effective weight loss agent, right? So in a patient without diabetes, Mounjaro goes by the brand name Zepbound for obesity, might get 22% weight loss, really outstanding. And it works for weight loss and diabetes as well. It's just not quite as potent for some reason, but still, about 3/4 of people get 5% weight loss. 40% of people approximately get 10% weight loss. 25% of people might get 15% weight loss. It's highly efficacious for weight loss. And almost everyone, look at these bar graphs here. 90% of patients who are treated with Mounjaro, really at any dose, will get to an A1C goal. If most of our A1C goal is under 7%, 90% of people will get there. And this is add-on to metformin, by the way. Same dosing advice, start at the lowest dose. In this case, the first month is 2.5 milligrams weekly of Mounjaro, again, subcutaneous once a week. And then the second month, you go up to 5 milligrams and then stay there. Anecdotally, the side effect profile of Mounjaro is a little bit better in my practice than for Ozempic, and we're not exactly sure why. There's some theory that the GIP might be protective in some way from the GI side effects. Now, there's lots of other data that suggest that tirzepatide Mounjaro is efficacious. They did head-to-head with Ozempic 1 milligram dose and showed superiority at 0.455% A1C lowering relative to Ozempic treated patients, about 12-pound weight loss relative to Ozempic treated patients in the same trial. So head-to-head, it was superior. It was superior to basal insulin, degludec, for glycemic control and weight loss. And like I mentioned, in patients without diabetes, you have outstanding weight loss. So yes, of course, I use this medication. Now, here's the interesting thought experiment. If a patient is well controlled on Ozempic, keep them on Ozempic. If they don't respond anymore to Ozempic, or the A1C is now rising on max dose of Ozempic, those are the patients I transition over to Mounjaro. And in a new start, someone who's naive to incretins at all, I'll start them on Mounjaro as my preferred agent. I will note that their cardiovascular outcome trial data is coming out later this year, so we don't actually know that there's a benefit or a risk, but we believe it's likely to be a benefit. Okay, there's actually quite a few drugs in this class still pending, actually. And in fact, many different concepts, a lot of orals, including a higher dose of oral semaglutide, 25 milligrams, which looks now efficacious, similar to Ozempic. Then we have non-peptide oral GLP-1 agonists. Orforglipron is most advanced from Lilly, but there are compounds coming from Pfizer, Structure, and Roche as well. There's an oral GLP-1 GIP dual agonist from Viking. And then there's an oral GLP-1 agonist amylin combination therapy from Novo. And there's also injectables basically for all of these same combinations, including, I think, very excitingly, a triple agonist, GLP-1 GIP glucagon called retatrutide from Lilly. And the preliminary phase 2 data from retatrutide was presented at ADA a few years ago. And as I recall, showed about 25-26% weight loss, which is just outstanding. It's closing in on bariatric surgery. Okay, basal insulin, I know I've talked a lot and I have a few more slides and I really want to get to my algorithm, so I'm going to go a little quickly. I think basal insulin I consider not last line therapy. There are some people who might need basal insulin much earlier on in their diabetes career. And again, I'll highlight East and South Asians who I think are relatively insulin deficient at lower BMIs. And so there are a number of East and South Asian patients I take care of where basal insulin is actually second line therapy after metformin because they're relatively insulinopenic. If we were to check a C-peptide, their levels are a little bit lower. There's a lot of treat to target algorithms. If you have a motivated patient in front of you, I just tell them start with 10 units of your favorite basal insulin and increase by 10% once a week until your fasting blood sugars are at goal. And I define their goal as a fasting blood sugar between 100 and 140. So there are a lot of patients I take care of who I start at 10 units, and the next time I see them 3 months later, they might be at 30 or 40 units. I mean, they've done beautifully with that. It's effective, but there's a cardiovascular neutral with weight gain, there's hypoglycemia. It's expensive-ish. Nowadays, it's less so because it's $35 a month capped across the country. And you could also use basal insulin with NPH too. In terms of the different basal options, I really do use them all interchangeably. There are several newer options, more concentrated glargine U200, as well as degludec from a different company. And they're really very, very similar. Technically, maybe some hypoglycemia benefit for the newer insulin, but those trials were aiming for a fasting blood sugar of 71 to 90, which is actually way too low for practice. So I do use insulin. As I mentioned, I like it in certain patient populations more than others. You have to overcome kind of the negative connotation of insulin that some people will have as thinking of this as more advanced disease. I think of it as replacement. So if a patient doesn't have enough insulin, then you replace it, just as I think of it in type 1 diabetes. I use them all interchangeably and usually base it on payer preference. So it's based on formulary typically. There is a once weekly, there's several actually once weekly insulins coming through. These are really quite interesting. So if you can easily conceive of an era, I hope it's in the next year or so, where you can do a once weekly shot of insulin just to get your basal needs covered, and then a once weekly injection of GLP-1 to cover your prandial excursions, to cover your food. So this is data from Icodec, but there's also a similar insulin being promoted by, I think, Lilly or Sanofi. Their initial foray was in type 1 diabetes, but I think the better home is in people with type 2 diabetes. Finally, okay, SGLT2 inhibitors. So the first one on the market was canagliflozin or Invokana, but since then DAPA, EMPA, and ER2. These are oral medications, and they've actually all had some level of cardiovascular benefit shown. All of them have renal benefits shown. There's no hypoglycemia. There's some modest weight loss. How to start these medications? Actually, they tend to be very safe, very well tolerated. The major side effect here is genitourinary side effects. In the beginning, people were very much concerned that it was going to cause urinary tract infections. The way these work, as many of you know, is the kidney is meant to resorb glucose from the urine, not to waste it, right? These medications block a key transporter in the tubules that will prompt that reabsorption. When you block that transporter, then the urine is now glucose rich, right? And actually, because the urine is glucose rich, then it could be fertile soil for, in theory, bacteria or actually yeast to grow. So the more common risk here is not urinary tract infection with bacteria, but actually yeast infections. And you do have to think about whether you want to prescribe it to someone who has been hospitalized for UTIs or yeast infections. There is also a modest DKA risk, diabetic ketoacidosis risk. This is more common in people who are insulin deficient. And so there are a number of people who prescribe these. In people with type 1 diabetes, it's a mistake, in my opinion, in large part because it does increase DKA risk. Okay, so efficacy, these are not very efficacious drugs. So if you take that same patient who's on metformin and their starting A1C is 8%, you're not really getting much out of it. It's about 0.6, 0.7% A1C. Really, they look like DPP-4 inhibitors. But in patients who are poorly controlled, their glucose levels are higher, and so you're blocking that reabsorption, so your benefit with the SGLT2 inhibitor is disproportionate. For instance, I have a patient who I started, her A1C was 14%. Started SGLT2 inhibitor, next visit, it's 8.5%. And I think it's just because it's the delta, what your blood sugar is and what your urinary sugar could be, right? So the higher your sugar is, the more likely you'll get a benefit. This was the data that was very surprising a number of years ago. This was from EMPA-REG. So this was the empagliflozin, which is Jardiance, showing a benefit in cardiovascular death and actually a benefit in all-cause mortality. Now, this hasn't exactly translated across the drug class. It's been shown for canagliflozin, Invokana, and empagliflozin, Jardiance. But DAPA and ER2 have just shown benefit for heart failure. These are truly outstanding heart failure drugs. They're beneficial for HFrEF, heart failure with reduced ejection fraction, and they're beneficial even in people without type 2 diabetes. So for the cardiologists in the audience, they might use these medications more than I do. And they're one of the few medications that are effective for HFpEF, heart failure with preserved ejection fraction. And again, it almost does not matter if you have or don't have diabetes. These are outstanding heart failure medications. And then renal disease too. So again, similar to the cardiologist, I think my nephrology colleagues use this more often than I do, actually, in large part because they're one of the few medications that have been shown to reduce progression of established chronic kidney disease, CKD3, to a hard renal endpoint. And again, these data are whether the patient does or does not have type 2 diabetes, which is just remarkable. So do I use these meds? Yes. They in fact are my preferred third-line medication after GLP-1, but they become second line and even first line in a patient who has diabetes and heart failure or diabetes and established CKD. I do like to combine metformin, GLP-1, and SGLT2 inhibitor. There's a lot of observational data showing potential synergy with this combination of medications. They're all either weight neutral or weight loss promoting, and they all work in different ways, so the synergy is obvious. I don't use in patients with type 1 or who have had recent DKA. There are people with ketosis prone type 2. Okay, I'm going to take a breath for a second. So now I get to my algorithm, right? This algorithm has a couple caveats. One is that we do discuss diet and lifestyle at every dose titration. You have another opportunity every time they come in to see you to discuss diet and lifestyle. And, we don't get trained this in medical school or residency or fellowship or really after. What do we mean by diet? You really want to try to reduce carb intake as much as possible, right? And replace those carbs with healthy fats or protein. So for my Indian audience, I'd say you should have naan or rice, but not both if possible, For my Italian audience, I'm like, if you're getting the pasta, don't have the garlic bread too. Just try to limit the big carbs to one per meal, no more, right? And the more you can limit the carbs, the healthier your glucose excursions will be. The other caveat I'll make is I may think that GLP-1s are the best thing in the world, right? But the patient might not think so. And if I'm trying to convince the patient of something that they don't want to do, they're probably not going to do it, or they're probably not going to give it a fair shot. You have to let the patient come to you in terms of their preference. Their preference is more important than your preference, of course, right? Especially when there are different options available. That all being said, these are my preferreds. This algorithm is color coded as well as shape coded. So the boxes are orals and ovals are injectables, and blue is weight neutral, green weight reducing, and black, which isn't showing up here, weight gaining. So in a patient whose A1C is pretty close to goal, for most people it's under 7%. That's the home of the DPP-4 inhibitor if it's a patient who you really want to minimize any risk of side effects. That's really the only person who should get a DPP-4 inhibitor. The preferred second-line agent for me, at least, is GLP-1 agonist or SGLT2 inhibitor, and I've already mentioned which ones I prefer within these classes. In a patient without whose A1C is above 7.5, and this is a patient who unlikely would even benefit from GLP-1 inhibitor, this is where I would prefer an incretin. In large part because of efficacy, cardiovascular benefit, renal benefit. SGLT2 inhibitor is another option if you have a patient who really wants an oral, but remember, it's unlikely they're going to get to goal with the metformin plus SGLT2 inhibitor because it's similar in efficacy to DPP-4. The caveat being you get the accessory benefits on heart and kidney most likely. Less preferred is anything that will cause an increase in weight. Those are the black ovals or squares here. So metformin and basal you can do, and again, in some populations you might choose to. Metformin plus sulfonylurea you could do, in some populations you might choose to, especially the cost conscious, but generally speaking, you wouldn't be reaching for that as your preferred second line. In very unique situations like NASH plus fibrosis, or now called MASH and fibrosis, as it was alluding to, that's the home of maybe pioglitazone. Very, very few people you would prescribe that to, in large part because actually Mounjaro has outstanding data for MASH and type 2 diabetes. If you have CHF and CKD, that should be your SGLT2 home. If you have coronary disease, that should be your GLP-1 or GLP-1 GIP dual agonist home. Now, third line. Here's where it gets even more interesting, right? And you can do any combination you want. My preferred combination is metformin, incretin, SGLT2 inhibitor, or metformin, incretin, and insulin if you need to. If your patient is, you think, insulin deficient, if they're lean type 2, they might need insulin. Less preferred are two weight gaining or hypoglycemia inducing agents. One note I'll make is it doesn't make much sense to combine DPP-4 inhibitor, GLP-1, and sulfonylurea. So they all act in the same exact way. They all push the beta cell to make more insulin. Adding multiple of these medications, increasing cost and probably increasing risk of hypoglycemia. The one thing you'll note that I didn't mention as an option really is prandial insulin, which is the rapid-acting insulins, regular or any of the insulin analogs. I think very few people with type 2 diabetes actually need prandial insulin. I think I inherit a lot of people on basal bolus sort of regimens who have type 2. I end up testing them off of the prandial insulin. I replace that with GLP-1. Vast majority do just fine. You might have to replace a little bit of prandial insulin with their highest carb meal. I went a little long. I'm sorry. I do tend to talk a lot. It's a topic I like, but I'd be happy to take any questions if we still have time.
Well, thank you very much for this comprehensive presentation. It's definitely a challenge to cover everything that has happened in diabetes over the last 2 decades in a short time. I very much enjoyed your clinical pearls, your clinical practice pearls, and I hope the audience found them useful as well. Colleagues, please, feel free to enter your questions in the chat. I'll start taking those questions right away. And there are plenty of questions already, which is fantastic. Utpal, first question, GLP-1 agonists, and Ozempic specifically, or others, the risk of ischemic optic neuropathy, the NAION.
Yeah.
And the question from the audience is, do you take into this consideration for individuals who may be at increased risk for vision loss, example, glaucoma or prior optic atrophy? How do you think about this risk in GLP-1 usage?
Yeah, it's an interesting point. You know, there was a paper published in JAMA Ophtho a year or so ago showing an increased risk in patients who are treated with semaglutide, either for diabetes or for weight loss. An increased risk of this NAION, which I don't think many people had heard of. Certainly, I had never heard of it. It seems to be an incredibly rare eye disease that seems to have an increased prevalence in people with who are treated with semaglutide. That one article, you could say, okay, it's one article, but actually it seemed to be replicated in a recent Danish
Right.
registry study. My thought on this is likely to be true. It may be unique to semaglutide since it hasn't been noted in tirzepatide. You can make the argument that semaglutide has many more patient year experience than
Yep.
tirzepatide. Um, the mechanism of this is uncertain. For many years, we've known that people who've rapidly improved their A1C have an increased risk of retinopathy. And this is often seen in people who are pregnant or trying to get pregnant and whose A1C they bring down from 10% to 6%, and they have an increased risk of retinopathy. And that's actually reversible after pregnancy. I'm not sure if this will be the same, to be honest. That being said, I don't know if it's a large enough risk um, to offset all the benefits seen with the GLP-1s. That being said, it is something that we have to think about going forward. I haven't stopped anyone on Ozempic because of it, but after the Danish registry study was published, I do mention this as a rare risk because I think you do have to inform the patient that this is a potential risk, even if it's a rare 1 in a million.
I would echo the same sentiments around the data as well as how it has impacted my practice. Same now, I feel more compelled to inform the patients. Otherwise, they'll find it from Google and make some choices. Risk-benefit ratio still supports use of medication like Ozempic, but it's our duty now to mention this to our patients. The next question, if uh, Niranjan could restate your question on SGLT2 inhibitor, that'd be great. The next question is, what's your opinion on diabetes reversal and your management strategy for this?
Diabetes remission is an outstanding goal, which wasn't really a possibility with medication, I think, until fairly recently. I think of diabetes remission as an admirable goal, one that is achievable through metabolic surgery. I'm an endocrinologist, I'm not a surgeon. Maybe someone here is. There's a long history of bariatric surgery showing type 2 diabetes remission rates. In particular, the more efficacious surgeries like Roux-en-Y gastric bypass, a little bit more than the more commonly done nowadays sleeve gastrectomy. But the type 2 diabetes remission rates with this sort of operation is very high, especially if you have someone who has only had type 2 diabetes for under 10 years. So I think remission is possible. The remission rates are, I think, highly correlated to weight loss. So, we are now approaching an era where we have medications that can achieve some level of reversibility, but I won't call it reversibility. I won't call it remission because you're actively taking a medication to treat the diabetes. So the likelihood of the diabetes, meaning their A1C going back up to 8%, 9% when you stop for instance, the Mounjaro is very high. But I think with sufficient weight loss through a different mechanism like bariatric surgery, I think remission is possible.
Great. Next question, Utpal, is there a role for testing serum insulin levels?
No. Definitely not insulin. You can test C-peptide if you're thinking that the person may have either type 1 diabetes or they presented to you with a history of ketosis, diabetic ketoacidosis. And in that patient population, you can consider doing two things. One, you could check antibodies for type 1 diabetes antigens like GAD65 and islet cell and zinc transporter 8. But I like to augment that by checking C-peptide. C-peptide is the cleavage product, as many of you might know, of endogenous insulin. Insulin is cleared by the organs, in particular by the liver, and there's incredible variability of insulin levels in the bloodstream. C-peptide is much more stable because it's cleared by the kidneys and it's dependent only on GFR, right? So if you're interested in a person to see whether they're insulin deficient, don't check insulin, check C-peptide.
Excellent. Now, can you comment on the use of GLP-1s and Mounjaro in non-obese patients with diabetes?
Yeah, it's really interesting. And again, I think you guys may take care of these same patients as I do. There are a number of patients BMI around 25 and they still have convincing type 2 diabetes, meaning, you've checked antibodies, you check C-peptide, they still make insulin, they don't have antibodies suggesting type 1 diabetes, but they have diabetes. In that patient population, you might want to think about what else they might have as a diagnosis. They might have something called MODY, or monogenic diabetes of youth, which is an inherited condition, especially if you've elucidated a family history where you can go back 3 generations and everyone has diabetes in their family and they all have BMI 25, right? Then you do have to be suspicious. But let's say you've convinced yourself that they have type 2 diabetes, they're just lean or not as heavy, maybe lean to overweight. There's still some benefit for GLP-1. Remember that it works in 2 different ways. One is on the beta cell, which is the part that I've focused on today, but also in the brain to reduce food intake. Here, I really do like the use of Trulicity. Trulicity head-to-head against Mounjaro or Ozempic is weaker, definitively. But you still get 1.4% A1C lowering and weight loss of only about 5-10 pounds, right? So there are a number of people who lose no weight on Trulicity, but still get 1.4%. So you get the beta cell effect without impacting substantially weight. Mounjaro, Ozempic, it's sometimes difficult for these particular people because they lose in too much weight. They don't feel well. They go from BMI 25 to 21, 22. They don't look well. That's not what they want. And so you do have to meet them in the middle. You want to get your glycemic outcome without actually causing harm or potential harm.
Excellent. Any more questions coming? So I'll continue this. The best preventive measures to prevent diabetes if you've been diagnosed with pre-diabetes and have a strong family history of diabetes.
Yeah, this is, I think, a common question among our age group and our people. There is a lot of family history of diabetes in the Indian population. We get older, we're going to be prone to it as well. The best preventive measure, in my view, is to stay active, stay healthy, try to eat balanced diets, reduce carb intake as much as possible. I think the activity level in this country is too low, frankly. Like every time you eat, you should be going for a walk. I think a little bit of activity every day. You don't have to run a marathon, but I think a little bit of cardiovascular effort every day. And the minimum I would suggest, and I do to all my patients, is a 10-minute walk after every meal.
A lot of my patients, when they ask this question about prevention of prediabetes, I quote the DPP program where metformin reduced the risk about 34%, but lifestyle and 7% weight loss led to a 58% risk reduction. So I just emphasize that lifestyle is so important for prevention. So
Yep.
completely with you. Next question is around Ozempic, and the answer was given by the audience. Once you take an Ozempic pen out, it's good for 8 weeks outside. So just something to be aware of. Next question is, any comments or experience with possible sarcopenia risk with the use of GLP-1 GIP drugs?
Yeah, so anytime you lose weight, and this is known from the bariatric surgery literature as well, it's not all going to be fat loss. It's going to be some lean mass loss. It's preferential in the fat compartment, but you'll lose lean mass as well. So people who lose like 20% of body weight, let's say in the Mounjaro Zepbound treated patient, you can think of them as the patient who might have lost 25-30% of weight in their Roux-en-Y gastric bypass. There is significant sarcopenia in some patients. Very few patients are symptomatic from this, I would say. I have taken care of a number of people who really did feel very weak as a result of the weight loss. So to combat this, once they've lost like 5% of their body weight, and even before then, as you start, you're starting an injectable, they're thinking about 100 different things. They may not register. But the next time you see them, they've lost 5% of your weight. These are the 2 things I say. Increase protein intake and increase resistance training. It doesn't have to be, you're not trying to bench your body weight. You're just trying to lift something, do some resistance training, increase protein intake. The guidelines on protein intake are rather broad, and there's no great data as to how much you need. Most people recommend 0.5 gram to gram per kilogram of body weight. I think if you're on a GLP-1 and you have lost substantial weight, that would be the minimum I would recommend, 0.5 gram per kilogram of body weight, and probably closer to 1 gram per kilogram. Difficult if you're vegetarian like me, but this is what you have to do, I think, if you want to try to mitigate the risk of sarcopenia.
Excellent. Many more questions, some about metformin being used for 40 years, or saying, hey, can one take metformin with GFR is 60 with 40 years of diabetes?
Very safe. There's no data to suggest it loses safety or efficacy with time. The GFR cutoffs, to be frank, I have people whose GFR is in their mid-20s, and I still keep the metformin on. You do have to be careful. When they're in the 30s, I drop it to a max dose of 1 gram a day instead of 2 grams a day. But it's such a good medication. It works in tandem with everything else you're prescribed, right? So it is have some sensitizer benefits. So even if you prescribe them insulin, the metformin will help it work better. If you prescribe GLP-1, it'll help it work better.
Beginning to end medication, I say vitamin M, right?
Mm.
Any suggestions on inhaled insulin? That's another question.
I use absolutely zero inhaled insulin. I never have, and I unlikely ever will. It's available currently as cartridges of approximately 4 units. It's in my mind a solution in search of a problem. Um, it's a little bit faster than subcutaneous rapid-acting insulin, but you lose some benefits of the subcutaneous rapid-acting insulin, meaning the dose titration. You can only use 4 units. You can't use, if you want 1 unit or 2 units or 6 units, you can't. You have to use 4 units. The other thing is you do have a reduction in FEV1, FVC ratio. So if you're prescribing the one inhaled insulin on the market, Afrezza, you have to do baseline spirometry and then yearly spirometry to determine it. I've had a few patients ask me for it. I tell them exactly this. I don't think there is sufficient benefit to offset the potential risk.
Utpal, I'll disagree with you on this one quite a bit. I've researched all inhaled insulin for the last 10, 15 years, including Afrezza. The pharmacokinetics and pharmacodynamics are substantially different than the subcutaneous insulin. There are two recent trials we were part of, both in type 1 and type 2. I think it's a medication. We just have to understand 1 unit is not 1 unit. You double up and round down. It does have a role. And if Afrezza was discovered before basal insulin, our patients would all be taking Afrezza at supper, because that's really the right treatment. The first treatment is not basal insulin. So
Hmm.
agree to disagree on that piece.
I love to hear a different viewpoint. Sometimes you get into an echo chamber of all the same viewpoint. This is great.
CGM is a game changer, but insurance doesn't cover for all patients. Any recommendations? I'm glad they brought this, because this is, go
Yeah.
ahead.
I like CGM very much, actually. So CGM is approvable for any patient who is taking insulin, right? Long been used in people with type 1, shown convincing benefit in people with type 1. More recently, a few years ago, there was a trial called Mobile that was published showing benefit in people with type 2 who are on basal only. And so that's expanded the playing field quite a bit. There hasn't been, I think, to my knowledge, substantial evidence to show benefit in people who are not on insulin. But I think there is some benefit there, actually. For me, I try all these things. If I'm prescribing something, I'll try it too, right? So I put on the G7, the G6, the Libre 3, Libre 2 over the years, right? The data is okay. It's kind of boring, actually. If you don't have diabetes, it's pretty flat. I've run a marathon in it. It doesn't change anything. You eat, you drink, except for the times that it does change. So, I was at a conference, I had a yogurt parfait. All of a sudden, my blood sugar on the Libre was 180. And so, it comes back down because I don't have diabetes, thankfully. But it is interesting, and I think that's the potential benefit to people, right? So they look at their data and they say, well, this are foods that cause my blood sugar to spike, and I avoid those foods as a result. That's the benefit. I'm not confident that it has a use case to enough to use it 24/7, 365 for someone who's not on insulin. But I think it is very interesting for people who want to use it for 2 weeks at a time just to see. And now that there are OTC versions of this, I think it's very accessible.
Excellent. CGMs, in my mind, are a game changer, not just a monitoring tool, but also behavioral modification tool. Well, we are getting close to the end of our time. Great questions, great answers. Let's see if there's anything else. Dialysis patients. So this is a great question. An underserved population with very few medications. So SGLT2 off-label in dialysis patients, GLP-1 in dialysis patients. What are your thoughts on that?
Yeah, I'm not comfortable with SGLT2 in dialysis just because there's not a lot of literature on it, though I do have nephrology colleagues who are comfortable with its use, and I actually don't think of a good reason not to think it would be safe. I'm not sure how efficacious it is, but they seem to think it has potential for efficacy. GLP-1s, again, also haven't been tested in this patient population. But again, I don't see any potential risk in that population as well. You just have to be comfortable with the idea that you're prescribing it in a patient who it hasn't been tested for. But I'm not particularly concerned for either in safety context. Dialysis, as you know, oftentimes patients might need much less therapy than they once needed because now their endogenous insulin will circulate at a much higher level because it's also cleared by the kidney, among other things. The other thing is the kidney makes glucose, right? So 15 to 20% of your glucose production, endogenous glucose production, is made by the kidney, remainder by the liver. So without that, actually, I have a number of patients who are on dialysis and they have fasting blood sugars in the 50s, perfectly normal, healthy, not on insulin. It's an interesting point for research. I don't know what you would think, Anuj. I don't prescribe a lot of it, but I don't have any problem with my nephrology colleagues keeping it on.
Yeah, our options get limited as the GFR goes down. And DPP4 is one area that I use in advanced renal failure. Many other medications just become very challenging. Last question I'll ask on the audience behalf is when somebody's asking, can we get the slides of this presentation? How can they get that?
Is it on recorded now, I think, maybe?
Yes. So it'll be available on the AAPI website in next day or two. We'll upload the whole presentation up there.
All right. Somebody put a last comment before I turn it over to Dr. Govil. They talked about PIO. Utpal, you and I also differ on PIO. I too like using PIO quite a bit in insulin-resistant patient, and there's a place for it in my treatment algorithms. But that's what the beauty of diabetes is. Now we have so many medication that we can really individualize and personalize. The great hope for patients with diabetes. Utpal, once again, thank you so much for this comprehensive review and taking all the questions. I really enjoyed it, learned from it, and appreciate it.
My pleasure. And thank you for, again, the invitation to present. I enjoyed it as well.
Thank you, Anuj, for moderating, and thank you, Utpal, for doing this. And we have a little token of appreciation. Vijay, are we able to project that? So on behalf of American Associations of Physicians of Indian Origin, we recognize Dr. Pajmani for his outstanding contributions in the field of endocrinology and diabetology, and welcomes him as a member of AAPI Distinguished Speaker Club. On behalf of Dr. Katula, AAPI President, and myself, AAPI CME Chair for this year, and thank you. Thank you again for a wonderful talk that you provided, and thank you, Anuj, for moderating the session, and we'll look forward to the next webinar.
CME.
Have a nice evening. Yeah.
Could you speak about CME before you go? How do people get CME?
So there is a barcode that has been just like a QR code here. Just scan that and it'll ask some questions, and then the CME company will generate the CME certificate and email it to you.
Right. Well, thank you, everyone. Have a good night.
Yeah,
Thank
thank
you.
you, everyone. Have a good night.
Bye.